Good morning, everyone, and welcome to the sixth Brunel Social Work Masterclass. Today, we are delighted to have Tiam Watson with us, who
Hi.
will talk about decision-making under pressure. Over to
Thank
you,
you.
Tiam.
Hi, thank you guys, and thank you for having me today back at Brunel University, but on the other side of the room. Before I kind of start, I do want to give you a bit of context and a bit of background about myself. So my name is Tiam Watson, and I am a social worker, but I am, well, as of today, I'm not, but I am was a senior social worker in a hospital discharge team. I am now, as of today, a service team manager in a hospital discharge team. I took some annual leave to come here and do this class for you guys, but I'll be back starting tomorrow. And I actually started my social work journey here in Brunel when the BA was a thing. That was about it's my 9th year qualified now. And I graduated, and I've actually been at the same council that I did my final year placement in. I started my journey as a community social worker. So I had the experience of seeing kind of what discharges or people were like on the other side of a hospital discharge or in the community, being able to consolidate my knowledge of, fundamental principles essentially in an environment which is a lot slower than a hospital context, and then take those skills into the hospital. So after 3 years, I became a senior social worker in a hospital assessment team, discharge team, and then that's where I had been ever since until I'm in my new post. And yes, I've done my ASYE, I've my practice education, and I've just recently completed level 5 in operations and management qualification. And yeah, so that's a bit about me. I feel as though I can say that bread and butter of mine now is kind of hospital discharge and something I really enjoy. I am also a neurodivergent practitioner. And when I actually started, I didn't actually think I was going to be picked for this. So putting that out there, I don't necessarily put that at the forefront of my discussions, but I think it's also something that's really important for me to talk about and discuss. And yeah, I actually think probably that's why hospital social work is quite fitting for me. Now, I do talk fast, and I did have a coffee, so slow me down if I know you need to and you can't hear anything, okay? But essentially, we are today exploring what it actually means to make decisions under pressure in hospital social work. And this is where kind of law, organisational demand kind of meet people's lives and interests. Now, it isn't about what's right and the right answers and what's perfect. It's just about defensible decisions. And I was actually showing Johan my cup that my staff got me, and I've left because I've just left. And it says, actually, let me get it out for you. It says, did you document it? Now, they say that's because it's me. So my kind of thing is that if it's not documented or evidence-based, it kind of doesn't exist. So my first thing is it written down? Is it documented? And I did find that quite funny, but it kind of sums me up. But before we get into that, I just want to outline what we will explore and cover today. So decision-making in acute hospital settings, law, ethics and organisational pressure, managing risk proportionately, multidisciplinary power dynamics, emotional labour and sustainable practice. So we're going to look at the realities of an acute setting, hospital setting, and the legal frameworks that shape and guide our practice and decisions, and how pressures also shape our thinking and our decision making. And lastly, how we kind of sustain ourselves in this type of work and manage burnout in the best way we can. Okay. Guys, this is meant to be an interactive session where as much as 5 people can be interactive. But I don't want to kind of talk too much, but I'm really interested in kind of your thinking. I know a lot, but I want to hear questions from you or just curiosity, and we can go from there, okay? These are the ground rules. They're not really, as in, make sure timing, we've kind of got past that. But they're going to be kind of complex situations that we may be discussing. So kind of don't make anyone that kind of identifiable. Just keep it kind of GDPR. And challenge each other's ideas and not one another. We work together, come together about thinking, and like I said, curiosity is more valuable than judgment and criticism in this case. I don't like the word criticism. I like the word constructive feedback and challenging, and that all comes into me being a neurodivergent as well, and how language is important, which I picked up in here. So, okay. What we're going to do is warm up a bit, got a bit of an icebreaker here. And the question is, when you think of hospital social work, what comes to your mind? And that is a space for you guys to let me know what you think. So what kind of words come to mind when you think of hospital social work? Is anyone in a hospital placement setting?
No.
Okay.
I don't think we've
you
got
are?
any.
I'll be going to St. Mungo's. Yeah.
Oh, St. Mungo's, do you? Oh, good people over there that help us when we have nowhere to place people. But no, it's brilliant. Oh, really? It's so interesting. So you have a lot of kind of communicational with, is it people?
I'm yet to start.
Oh, okay. So what, in St. Mungo's? Is that where your placement is?
Yes, in April.
In Ealing?
Yeah.
What's your name? Ben?
Ben.
Oh, so do you work for Ealing Council?
Ben.
Oh, okay, brilliant. Okay, brilliant. So give me some words, guys. Give me some words.
So when someone's being discharged home, so it's the in-between from hospital to home.
Waiting. Waiting. Medically optimised, medically fit.
Yeah.
Is that what you're looking for?
Medically fit.
Okay, yeah. So
To leave hospital.
Oh wow, that's very small, isn't it? Okay, medically, yeah, fit. We say medically optimised now. Yeah, we've got some vinegar for that, okay? Yeah? Once you had your hand.
I was going to say I was in a hospice setting.
Okay. Yeah, hospice. Okay. Is this now?
No, first placement.
Oh, okay, brilliant. But I'm still going to put that there because that is actually. But words, hospital discharge. We're thinking of discharge, getting someone out of hospital. Give me some words, what you think associate with that.
Equipment.
Equivalent?
Equipment.
Equipment, good. Equipment. This is actually quite interesting. Yeah? Just shout them out, guys.
Care, community care in the community.
What community care?
Continuation of their care.
Okay.
Assessment of needs.
Assessment, yeah.
Of needs.
Okay, and a few more? Any more?
Well-being.
Good. Excuse my writing, guys. And well-being. Okay, that's very interesting words, actually. Aftercare, okay. Okay, cool. Yeah, so I'm seeing. Is there a theme here? Is there any theme here? I'm actually genuinely asking. They're not words I had done, but this is it's good. They're good. Good. What do you know about reablement? Yeah. So okay, these are good words. So other words that I had: so pressure, risk, urgency, safeguarding. Good job. Yeah. Good. And that kind of those words and all of these as well. Absolutely, all are part of it. Kind of form the hiya. Thank you for joining us. That's all right. Those are realities of the environment. This is what kind of shapes the discharge and reflects the reality of a hospital discharge setting. Now, hospital discharge sits kind of right in the middle of. I'm going to go back over here. These tensions, okay, because decision making by us particularly as well has to be done quite quickly. As soon as you hear the words medically optimised or medically fit, it's like, right, over to you, social work, and you've got to do what you've got to do. Now, whether they actually are medically fit and medically optimised, there's a lot of challenge that comes with that, and we have to clarify a lot of things, but that's where it's kind of their responsibility is done and kind of over to us. And this involves kind of balancing the kind of legal responsibility, so all the Care Act, the Mental Capacity Act, mental health, all of those law and legislations that are important, organisational pressures, and people's rights and well-being, because essentially, who is at the forefront of these decisions? The individual and the patient. So how do you ensure that that is always followed you have to ensure that they're able to make decisions or can about their care, and where they can't, we support them with that. So before we get into the decision-making side of things, I think we need to ground ourselves in the context of what we're working with. And that is here, understanding the acute context. I'm really glad you said medically fit for discharge, or that, because that actually is what everything is kind of based around, that one phrase, and that's where we start our intervention as social workers. Well, we hope to actually start it before, be involved in the multidisciplinary team discussions, the board rounds and the meetings, but we'll get there. So acute hospital settings are fast-paced. They have medically driven timelines, bed pressures, so these words, rapid decision-making is required, and that is like kind of the medical model. So we have two models, the medical model and the social model, and they often conflict, right? We've been working for many years to be harmonious and try and have that kind of harmony, but yeah, it's still a work in progress. And then when we look at social workers in our lens, it's about autonomy, it's capacity, safeguarding, well-being, good job guys, human rights. And I don't know, can you see kind of, so there's medical model and social model. In terms of the, what's the words, the kind of, what's the, I'm trying to look for where we're coming from as social workers and where it can be perceived that they're coming from as a medical. So let me be as objective as possible. Medical model naturally is more of a prescriptive. When you come into hospital, you're kind of at your most vulnerable and your quote unquote worst. You're looking for treatment, and I think for me, what I've observed is they're prescribing. They want to, it's diagnosis. They're kind of giving you a something, based on their kind of tests. And with social work, we come in, we're empowering, not to say that they're not, but they're not, that we're empowering. We come from this kind of, what can you do for yourself? What do you want? We look at them as a person as opposed to their label or what their diagnosis is. And I think often where that conflict, and I reflect on myself, and I can come in, I think they're tired of me at this point, but that's because I've been doing it for so long, and I'm very kind of process driven, but also it's easier to follow what's already there for you. So we have this home first principles, which we all follow. Least restrictive. What does that look like? The person at home, before we start giving them these things, what do they want? We have law and legislation that enables us to extract those thoughts and views from those who are deemed to be incapacitated or are not able to. So we can use that. So yeah, it conflicts because we come in like the superheroes, come in unrealistic almost, and that's where we have a bit of challenge. So anyway, the phrase medically fit for discharge carries significant weight in hospitals. However, social workers consider those things at the bottom. And an example might be at 4:30 on a Friday, we might be asked whether someone can safely be considered to go home. The bed pressures, the ward needs a bed, they're in black escalation, and the family want them home. They've been in hospital too long now, and it's us as the social workers that need to make that decision, use our professional decision-making autonomy to support with and manage a safe discharge. Yeah? So what anchors our judgment in these moments? Well, these bad boys here. There's lots more, but these are the main legislation law. Is anyone familiar with these? Is everyone familiar with? Yeah? Okay, brilliant. So now law doesn't remove pressure, it structures it. Yeah? And these are for me, did you document it? I'm quite surprised that's a new one, but mine is about, I often believe things become a lot more complex when we just don't follow what is already in front of us and what is there for us to be used. Now, these are there for you to refer back to and use that to inform, guide your decision-making and your rationale. If you can say, but how did you come to that? Okay, the Care Act says this, or the principles of the Mental Capacity Act says this, or under this, that's evidence in your practice, and you protect yourself. My staff they were fed up with me, but they soon realised the word of the year I said was accountability. Didn't like that one. I said because it would be when I started to take myself out and And, you know, it's kind of a comfort they have, and it's what was your rationale, not what do I think. I don't know what, I wasn't there, but I can evoke thought and questioning. And it was hard for me actually, because you become accustomed to just giving the answers or say, do this. But when you evoke that thinking and they become accountable, I started seeing bits of the care act I'd never seen before. And I was like, all I had to do. So yeah, so like I said, it doesn't remove it, but it does structure it. Now, can anybody, it's not a test by the way, it's just, can you remind me of, or just let us know or refresh us about the principles of the Mental Capacity Act? Do I even know them? Yeah, I do. Quick sense check. There's 5. No? Don't be shy, it's not a test. Yeah?
Taking the least restrictive
Good job.
method or intervention.
Exactly, yeah. Doesn't have to be in order, by the way, either.
Yeah.
But there's just a preface, doesn't have to be in order.
Acted on behalf of clients or customers, so to speak.
Oh, good. What was that word?
Best interest, yeah.
Good job. Yeah, so least restrictive, best interest. That's 2 out of 5. Good job.
And it says, I think, sorry.
Good job. Yes, that's the first principle. Yeah, so we presume capacity. Yeah. So when someone comes to me and says, "Oh, they don't lack capacity," that doesn't even make sense to me. It's you presume capacity, and if you have a reason to doubt, so you haven't completed this assessment. You didn't complete one because you had no reason to doubt capacity. Even the framing, like I've had to unteach certain things or with staff and just become more. What's the phrase? I'm going to make this up now. It's kind of like like kind of literate in terms of law. No, I don't know. Just enable them to be able to explain their rationale for things and their understanding of what they mean. Because I don't know what you mean either. Do you mean? Because medical team are very smart and they will look for, unfortunately, gaps in, or wording, or you said that they had capacity or whatever. And, it's kind of like, well, no, I had no reason to doubt. I didn't complete one because I had no reason to doubt. And that completely eliminates things. So you have to, at the beginning, be very clear on what it is you mean. And until you challenge that, a lot of the staff kind of don't know what they mean. But I think I've had to undo years of kind of a culture where people are comfortable because there's more pressures now and you have to be more accountable and your practice has to be more defensible. So we've got least restrictive, best interest and presumption of capacity. There's 2 more.
And there is unwise sorry.
No assumption of assumptions based on their conditions or characteristics.
It says unwise decision.
You got there? You Googling it here?
Sorry?
You got Google up there? That's good.
No, because I worked in mental health.
Yes, good.
setting, so
yeah, keep going.
it's unwise decision and is it least restrictive options?
Yeah.
Yeah, least
Okay,
restrictive
so look,
options.
so we got the first one's presumption of capacity, and the second one's we have to support them to make the decisions.
Decisions, yes.
We have to support. It doesn't mean give them the answers, but we have to support. We have to kind of do our best to give them a good shot and a good chance. And I will say the biggest, I think that they struggle with the most, I've identified, is mental capacity. I don't know if you find that. People really find doing mental capacity assessments challenging.
Yeah.
Remember, it's decision specific as well.
Yes.
Someone could have capacity in one area, but lack it in another. Yeah.
Because it can be fluctuating.
All of that.
Yeah.
So you have to go back. It could be time specific. It's laborious, but that single kind of legislation is really fundamental in our line of work because that can change the trajectory and direction of the discharge, yeah? So unwise decisions do not equal incapacity, yeah? Best interest and least restrictive. Now, these principles are super important because they anchor our decision making, and that's exactly where hospital social work becomes complex. Okay, these are some words here. So what defines and who defines readiness? So medically stable, functionally safe, legally sound, organisationally convenient and personally chosen. Right. Now, I was saying it briefly before, but medically optimised and medically fit does not necessarily mean socially ready and stable. And this is where it comes in. There's a number of factors that lead to a safe discharge or for us to manage an effective discharge. I think one of the words over there was equipment, community aftercare. that all forms part of the discharge process. But how do we get that? From a character assessment. There's an assessment over there, wasn't it? And that is what we need to do, and that's kind of the rush, and that is where we have to complete a holistic assessment, so consider all elements of the well-being, because that's what drives. It's not just about thinking in isolation about the medical needs. That comes together to inform the outcome. So this is where it becomes layered. And we're on pressure and professional judgment, yeah? These are the pressures here that shape decision-making and the outcomes. So it's the bed flow targets, delayed discharge pressures, you can see here, resource gap, so time, time, equipment, and availability of agency, family members to support, the professional pressures, so accountability, defensive practice, documentation, scrutiny. Yeah, did you document it? If it's not there, it doesn't exist. And personal, so emotional load, cognitive fatigue, and time scarcity. Now, which of these pressures do you think most influences decision making in practice? Any was it? Which one?
I think for me, sorry, I think the first one, system, bed flow target, display discharge pressure, and resource gaps. I think that's the one for me.
Sometimes I'm thinking personal, emotional.
Should I pass up the microphone?
Sorry.
That's okay.
Cognitive fatigue and time scarcity. I think that's basically also around something you mentioned, which is family, ready, and whatever. Yeah.
Okay, so
and if the person actually feels they want to go.
right, yeah, they love I'm not ready.
Yeah.
It's comfortable. You get comfortable, don't you?
I think they all three have the same impact. They're equally the same, because based on my experience, there wasn't one that was more important than the other, because you could have a situation where, yes, you want everything is accounted for, and then the person wants to go, but then there's a delay, or vice versa. So it was all interconnected. So all ducks have to be in a row, and most of the time in that setting, they're never in a row.
No, that's a good point. Thank you so much for that.
I think in an ideal situation, you can never have.
Let me know
all.
when ideal comes. When
Yeah.
ideal comes.
Yeah, so you have to make a choice. Yeah. Together with other professionals, especially the medical side.
So you're talking about because it kind of leads back to your point in terms of, so for me, it's rarely just one ever. They're all interrelated and they're all kind of synonymous. They work alongside. You're always going to have a bed flow target. Hospitals are, it's all about, we need everyone out. It's A&E, the ambulance are blocked up at the front door. What can I do? I can only move as much as I can, but do you know what helps? When they actually have their things in order. So I think it's when we look at accountability and professional accountability when that comes in, but they're all interrelated. It's rarely just one pressure. Yeah, like I said, it's usually all happening at the same time. But I think what's important is to look at and separate what is an organisational pressure, what is the family pressures, what is due to equipment delays, and kind of categorise that, come together and not blame one another, but to see where the gaps are and come together with a plan. Which, social workers have a really integral role in facilitating that coming together. We often get, a lot of pressure from the families. It's over to them, they're taking long doing their assessment and things like that. Mind you, we're trying to clarify. You said they're mentally optimised, but they're on a course of a 7-day antibiotic and they're on day 4. So how can we do an MCA when they're still experiencing a side effect is confusion? It's not fair to assess someone when they're confused. So there's lots of nuances that arise that we have to be accountable for, and we absorb that pressure. So that's where the emotional load also comes in. So what happens under pressure? So cognitive narrowing, risk inflation, heuristic thinking, emotional override, and the Friday afternoon bias. Do you like the Friday afternoon bias? In these circumstances, okay, if I speak for myself, what happens under pressure, I've evolved quite a lot, and I see it more in my students and my staff, and it's interesting. So I think for me, and being a neurodivergent practitioner, it's like, okay, prioritisation, organisation is very, very challenging and difficult. What is important? What is a priority? And what can be, managed in this way? And I think for me, as I did my level 5, and that was a huge module in that. And I now use like a matrix to assess what's urgent, what's not urgent, what's a priority, what's now. But I think it's like slowing down. You can't do everything. And I often put it back to the team. So we got 10 discharges, let's say 15 discharges. Okay, so which one would you like to prioritise? Because you want them out. Of course, it's in our interest to get them all out, but we have to be realistic. Not naturally, it's easy to be like, okay, what we're going to do? Okay, we've got 15 and I'm trying to figure it out. No, and I've learned massively to kind of put it back, work together and kind of balance that load and put it back to them, okay, which is a priority? What are the small package of care? I can't do a placement that quickly. It's not realistic. We can assign them, but let's get the small package of care out. What can go through reablement? What can go through bridging? What family can bridge until package care is in place and handed over to the weekend team? So it's about that kind of thinking. And it is so easy to become so stressed and pressure, and there is no mercy given by the ward. And they're not bad, but it's everyone for themselves. They do not care. They just like to see results. And I'm quite results focused as well. I'm also realistic, but I also learnt to under promise, over deliver. And I'm also just real. I go into hub calls every single day. I covered the 2 biggest hospitals I did, and I had the most staff. So we had hub calls every day. There's only so much updates I can give to you. 2 escalation calls a week and then 1 main MDT. That was just for my 2 hospitals. You are getting more than enough information. Furthermore, what can you give to me? But I then got access to their system. So I didn't even need what they had to say. But it's about also developing and building those relationships. Yeah, that alleviates your emotional load because you build trust. You can rely on people, and it becomes that kind of joint working in that type of way. What can you do me a favour? Yeah, and then it's just about being realistic. And I think they respect that more. I never say anything that I can't do or achieve, and they respect it a lot more. So I've had to kind of teach staff that, because when you're then on the ward, as opposed to, to be fair, I still got the pressures because it gets escalated to me, but when you're face to face and there, it's different. So you have to acknowledge that. Okie dokie. Yeah, so basically, thinking can narrow, risks may feel inflated, and professionals may rely on mental shortcuts or heuristics. Yes. So risk tolerance on a Friday. I had a staff member, I think she cried, and I said, we're not doing this. We're not doing that because, but I got it. But I think we'd been here before, and it's like, slow down. Suddenly the person needs an increase in their package of care. Okay. But their care agency also everybody has a responsibility and duty, not just us. And I think it's about reminding people of that, and staff, and building staff's confidence to remind people of their responsibilities and their duties as professionals and people who are caring for vulnerable people. You need to find a way to manage that risk in the same way we would. And it's about, I was like, it's interesting that suddenly it's taken years to get to this, and so it's hard for me to teach staff in a small amount of time, but I also know how agencies can think, and some certain tactics, and suddenly someone needs an increase over the weekend, we feel pressured and we'll increase it, and we haven't done our proper risk assessments. So yes, about slowing down, but I do acknowledge how emotions can override with those additional pressures. Now, I'm excited about this, kind of want to get onto this. So it's the case study, because I'm quite practical and I like to just put the thinking into kind of action. So we'll have a case study. We have big enough class now to split into 2 groups. Thanks everyone for joining. And we'll have group A and group B. So one will have Mrs. K, capacity and risk, and someone will have group B, safeguarding autonomy. And I want you to discuss the following questions, okay? So what are the key risks? What legal frameworks are engaged? What would proportionate intervention look like? And what makes your decision defensible, okay? need to appoint a note taker and a spokesperson, and then you'll have 15 minutes, okay? Did I? Oh, sorry. It would actually be helpful if we split it. Take a picture of both, because you're going to need, it's in your interest to know both. So let me know when you've all taken a picture of what A. Yeah? Good job. You can airdrop it to each other, and then B. Yeah? Everyone got B? Sorry. Got it? You need it? There you go. Yeah? Right. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, hi. It's going to be 5 and 4, isn't it? So 1, 2, 3, 4, 5, 1, 2, 3, 4. Yeah? Is that okay? Yeah? When you're having your discussions, kind of structure it in terms of like, so I was writing this down. So what risks do you identify? Yeah? What legal framework you recognise? How you're balancing autonomy and safety.
Sorry, how we?
Balance autonomy and safety, yeah? And whether your decision is proportionate and defensible. Thank you, guys. I was walking around a little bit, so I did hear some really thoughtful conversations and discussions happening, which is all really good. You seemed really engrossed into what you were speaking about in the case studies, which is always very helpful. So I want to hear back from the case study 1 first, so Mrs. K, capacity and risk, group A. So I'm actually going to read through the case study and then you guys feedback. Yeah? Guys, I have your attention. Thank you.
Who's going to feedback me?
Okay, so Mrs. K is 87 and was admitted following a fall at home. She is now medically fit for discharge. She lives alone in a 2-storey house. Mild cognitive impairment has been noted, but her presentation fluctuates. Mrs. K refuses a care package, stating, "I've managed all my life." Her son reports increasing forgetfulness and near misses with the cooker. The ward team are expressing urgency due to blood pressures. Okay? So, group 1, talk to me.
So we said for number 1, what is the immediate and potential risks? We put risk of another fall, self-neglect, kitchen safety, medication management, and fluctuating decision making.
Sorry, too much noise. Sorry, sensory issues, guys. Too much noise. Sorry, could you just repeat that? Say that again, please.
Yeah. So we said risk of another fall.
Yeah.
Self-neglect.
So falls risk.
Yeah.
Yeah.
Kitchen safety.
Self-neglect.
Yeah. Kitchen safety.
So what about the kitchen?
Risk of fire.
Risk of fire.
Mm-hmm. Yeah.
Medication management.
Okay. Mismanagement.
Yes.
Yeah.
Mismanagement. Yes. Mismanagement. Yes. Mismanagement.
Yeah.
Okay.
And the fluctuating decision making.
Okay.
Yeah.
Okay.
And then we put what additional information is required. For 2, we've put functioning ability, what strengths, care and support needs.
So you've put, what additional information is required you've put?
Functioning ability. So what are her strengths? What support does she have in place?
And who assesses that?
Do by herself?
So you said 2 things here. So functional ability. So so who assesses that?
The social worker.
Assesses a functional ability.
Oh no, that's a medical. No, that's not the social worker that does that. But what we'll do.
Occupational therapists and
So
physiotherapists.
that is coming from hospital team. I would say maybe sometimes hospital team do that before they discharge patient.
So, yeah.
We did also add there that we'll find out if she's got LPA.
Okay, brilliant. Really good.
Yeah.
Really, really important.
We said home environment. Oh,
Sorry, because so just to slow down. So OTs and occupational therapy in hospital, because they're in hospital at the moment. Okay, and you're saying you'd complete an LPA search to find out if there's any lasting power of attorney. If just in case anyone doesn't know what that means, can you explain briefly what that means and the importance of that?
The importance of that is if she has an LPA in place for her health and her finances, it means that whoever the LPA is, because she has a son there who's mentioned, they might be much more important in the decision making around her care after care process. they
Yeah.
could make some decisions for her on her behalf.
Good, really good insight. Just to provide a bit of clarity, so a lasting power of attorney has the legal powers to make decisions on behalf of the person who's appointed them as an LPA. And the important thing with an LPA is what? How does an LPA come into effect? When? At what stage?
When
So
capacity
if you
is
find,
questioned.
correct. So no, well, if you find that someone has LPA and the son has an LPA, he doesn't automatically get the right to make decisions. It's when the person is what? Determined to
Lack capacity.
correct, yeah. Yeah. So a lot of the board loved, oh, there's an LPA, that's nothing to do with me, not interested. For as long as we haven't done a mental capacity assessment to determine that the person lacks capacity, it's neither here nor there, but it's good to always know. And one thing I make sure before they even go out and assess, you do a land registry search to know who owns the property, because one of the biggest barriers to hospital discharge is, oh, don't want them back. Whose home is it? Well, it's their home, they can go back. And that'll be the first point. But also, who has the legal powers to make those decisions, yeah? So we can just anticipate, and that's the early intervention. So sorry, yeah, continue.
So still 2, what additional information is
Yeah.
required? The home environment.
Good job. How would you get insight into the home environment?
Speaking to the family, speaking to herself.
Sorry. Can I join in with you?
Of course.
Okay. Say, for example, we have this patient coming from, it's a discharge to assess. They're coming from hospital. So we have, we can go in and assess the home environment as a multi-agency.
Okay, good.
In terms of social worker, maybe if we're going to put in a package of care, the community team, and also like a care service, and also we have the OT that comes in at the same
Take
time.
pictures.
Yes.
Yeah,
And
measurements.
We do like a full assessment of
The home environment.
the home environment
Good job.
and the safety equipments and everything to ensure that everything is suitable for the discharge. And
Brilliant.
yeah.
Good. That's brilliant.
Community as well. Who can help, who's helping, what does that help look like?
So the informal support, the community support, and the informal support network.
Yeah. And then we moved on to 3. How would you approach assessing capacity? We said listen to her views, use clear language, functional tests, which is the understanding, retain, weighing up, and communication.
So you would approach assessing capacity by what's the first thing? Based on the principles of the mental capacity and the first principle, what we discussed.
As capacity.
And if there's a doubt, and then that will trigger for it. So you go with the assumption that she has capacity, yeah? And there's a mention of fluctuation, so talk to me about that.
What it looks like for different things, because although she may have capacity in some areas, she may not have capacity in other areas.
Also the timing, she may be better in the morning or the afternoon, so it's more decision specific. What particular decision are you doing in relation to? Because sometimes, her medication, it's not our remit. They do MCAs, the medical and clinical teams, about medication and clinical things. They try and sneak it in there, and then it's for us to do about care and support needs, discharge destination. But also sometimes they kind of cross over, and that's why I always encourage joint assessments with physiotherapists and OTs, because the functional capacity assessment also, that all impacts the outcome, and that also is another thing. But yeah, continue. That's brilliant.
And then
so if she lacks capacity, what would the route be?
Best decision. Best interest, sorry, yeah.
Okay, and
least restrictive.
Good job.
That's what we said in 4. What would the least restrictive option?
But yeah, don't go into it yet. But then, and if they didn't have, she did have capacity.
You have to respect her wishes. Why safeguarding?
But wait. Go on to 4. So what would a proportionate? So for both outcomes, what would a proportionate intervention look like?
So we put least restrictive option, respect her decision.
What would that call? What do we call that though? Because it could be respect. What's her decision? So she's managed all her life, right? Increase in forgetfulness and near misses with the cooker. What would kind of what kind of conversations would you be having with her? But what conversations would you be having with her? Because we can't negate from the risks that have been identified and the concerns that have been highlighted. So what kind of conversations would you have with this person? Let's say she was like, you've decided, you know, part of your assessment, you would have gathered information, you would have seen the realities of certain things, because part of your assessment's kind of, it's not a test, but you're assessing what they're saying against what the evidence there is. So if the home environment's not safe, or these things, or what's been gathered, how are you approaching a conversation with this individual? Because remember, it's not about eliminating risk.
Yes.
It's about managing risk. Yeah, and managing a safe discharge. So how would you approach a conversation with someone like this?
Encourage a fire risk assessment so that she can have check that she's got the fire alarms and stuff that will alert her when there's a problem.
Assisted technology.
Good job.
Yeah.
And also how to manage. You ask her the things she can do,
Yeah.
and then you gauge from there.
Good job.
Yes.
Good job. So you take what you have established and got from the OTs, the SANs, that information. You ask her. You don't. You ask. If I'm a bit of a part of me, be like, you know, they're trying to put you in a. They're trying to. The ward want you in a hut, like, let's talk. They're human beings. I'm like, they want you in a hut. I don't believe that. So I need you to talk to me.
Yeah.
They're saying your home's in a state. I've seen pictures. You show the pictures. Why are we hiding? And see what they have to say about it. Now, let's be very clear. My standard of cleanliness may be different to someone else's. Let's be very clear. I'm not here to judge someone on there, but there has to be an understanding. You know, I could see why people would think A, B. I've lived like that for years. I've managed an A, B, and she had an infection. That's why I came in. So until she had an infection that caused confusion, that led to a fall, she was living fine.
She was fine.
So it's about, approaching the conversation with the information you have and giving them opportunity and ability to kind of buttress that or counteract that with what their views are. But you should also help them understand what the risks are. And it's when you're talking about unwise decisions, it's about being fully informed. Yeah. How can someone be fully informed? They have to have all the information presented to them. That includes the professionals who are against certain things. So they like to send you into alone. No, everyone's coming. Let's all have a conversation together because that's your expertise. You're saying there's a falls risk. That's not for me to over-explain and get into. Explain why that is a reason why enough for you to say this person can't go home. Do you understand? So bring everybody in so everybody's accountable for their area of expertise. And because everyone will come back and be like, that's not, you don't know. You're right. Do you know what? You are so right. Come and help me. And I've learned that because it's like, I could say I know a bit about being a doctor. I know some medical terms now. I know about the function, and also I read. They're very similar, their values to us. They can't stand that. But we all follow similar but same kind of principles and guidance. You approach the conversation, giving her as much information. She's aware of the risk. She can tell you, I'm aware of the risks. I still want to go home, but I'm open to A, B, C, and D, assistive technology, this A, B, and C. I'm aware that if I don't use it, I could fall. That is how you assess insight, understanding, and then you can, and that's a level of depth that a lot of people, because we're afraid of being too intrusive, to naturally, I ask a lot of questions, I'm inquisitive. A lot of people, and I've learned, are not really, it's hard and you're asking someone personal things about, what's going on, your day to day. You're not used to that because you have to get busy as a social worker and be nosy, but in a respectful and in a way which is to help. But yeah, sorry guys, because I don't want to go on, but yeah.
I was just going to add that I have discussed with my colleague that the fluctuating capacity, the mild cognitive impairment, could be also due to an infection, but then it was not presented. So for that reason, we cannot make a decision in terms of her capacity until if she's on a course of antibiotics to be cleared up and to give her a bit of time.
It goes back to that, doesn't it? Medically fit for discharge.
Yes.
What's the first thing you make sure before you go and do anything? You actually make sure the person's medically fit for discharge. They love that term, but you get back and you check all these things. That's what I'm saying. There's a lot of social workers dive in deep, let's go for, I come back and I was like, but I was on a hub call and they said this person is on their fourth, and then we're going backwards, we've decided this. But I can see uploaded, there was an LPA search done and someone's got an LPA. What have you've just wasted all that time when someone could have just taken and done a decision for you. Do your background research. Before you're doing any of this, go and read through her previous case file to see if there's any history. Yeah, is there private carers involved? It's easy to rush, and the pressures of the hospital environment and the pace tricks you and makes you think, and slow down. Because funny enough, it seems that their lead professionals are medically fit, ready to go. You lead discharge as a social worker. They hate that. They love it when it's, oh yeah, but it's down to you. It is down to me. You're absolutely right. And nobody's going anywhere until I do the appropriate assessments and I have the relevant information that's required. And that is how you evidence your work. You can say, the delays with me is actually it's over there because we didn't have the relevant information. And that's how we've been able to highlight and make people like be accountable, different professionals, yeah? So before anything, you go into that. And that's how you can assess proportionality, because you can see that someone, if without knowing a person and their background, you can't make or advise about anything. And you can't say to them and decide for them what is appropriate and what is not at all before you even have a little history. Even knowing where they grew up, you know, let's say culturally, it's a West Indian person who's like there's certain cultural nuances that you have to be aware of, certain ways of living. I speak for myself, I'm West Indian. Accumulation of stuff in my nan, she likes to accumulate things, or like it's just to send back home in a barrel, you know, that kind of culture. Like someone could come in, it was a bit out of control, we managed that, but you have to, someone could come, it was a bit cluttered in here. No, what are the risks, the false risks, and to what standard are you judging that by, yeah? So your own personal biases you have to be aware of as well.
And another thing that sticks out is the fact that she's got a 2-story built house. So she would have to explain if her bedroom is upstairs, downstairs, how's she going to manage that to make sure that she reduces the risk of fall. Would she like some support just for the first few weeks until she gets back to base, where she can actually do all these things by herself? Or, you know, just highlight the risk of fall if she has to keep going upstairs.
So what would you offer her? So you talk. What would you offer her? I've meant you like short-term support. So you've said she's declined. What things would you kind of offer her or advise her?
You could offer her somebody coming in once a day to support her in the morning.
Is that chargeable?
Sorry?
Are you talking about reablement or long-term care?
Reablement.
Okay.
Not long term. Just a short term. Because she says she can manage all her life, we kind of look at short term, and from there you can assess if she needs more.
What about the cooker and the kitchen safety?
It's a very big one, which is why I suggested the fire risk assessment, quick risk assessment.
Isolate the gas cooker. Use a microwave, isolate the gas cooker.
That would determine if you want to.
But before we do any of that, we're talking about her forgetfulness and a bit of confusion.
But even before we get to isolating the cooker, we can ask her what her meal times are like, because she might be open to microwave meals.
But you mentioned kitchen safety. Who assesses kitchen safety?
She did. Y'all did. Come on in. Yeah, what's kitchen safety?
For kitchen safety to be assessed, we need to make a referral for the London Fire Brigade Service to come in, and in terms of smoke detectors and stuff like that, to put that in. The other safety of the kitchen would be whether she is able to manage cooking her meal, preparing her meals.
But what's a near miss with a cooker? We're assuming where there's issues. Son said about a near miss with a cooker. I want to know what's a near miss with a cooker? Near miss that she nearly dropped on the cooker? Near miss that she. What does that mean?
That's what I'm thinking. The near miss, is it because she left the cooker on, or
we don't know,
or is it that
does the son live with her? And when did he
almost fall?
How did he report? Like, does he live with her? How is he? Was it fed? But is it a one-off? What's the frequency of it? These are all the questions you need to ask, because remember, people's own anxieties can inflate a situation and a circumstance. And I think you worry naturally about your family members, but they also have a different way of living. I think for me, it's just about language and words and certain things that we have to delve deeper into. Yeah, you see the pressure of urgency, need to. But my point is, if you can see, what is your role as a social work team in this? We've already spoken about how many different professionals are involved. You are central, but that informs your whole assessment is from the OTs, the physios, the community care support, the sun, that support, all of those things inform your assessment. So it's really important to know what your remit is, what your role is, and know when to kind of step back and leave it to other people and what that kind of looks like. So, I just want to go through quickly. The mild cognitive impairment, right, has been noted. What does that mean?
It says mild cognitive impairment. That means that she has some problems with memory. Or
Who's assessed that?
According to that would come from the doctor who would make that assessment, because we are unable to
So it would have been like a mocker or
Yes.
they would have done their own assessments that would indicate a mild cognitive
Mild
impairment.
cognitive impairment.
But also you would do through a memory clinic.
Yes.
You would ask them if they've diagnosed her or any
Yes.
like GP.
Yes.
You'd gather that information. But someone who may have an impairment or cognitive impairment does not necessarily lack capacity.
Yes.
It doesn't equate to that. So
Yes.
we start with we go in that they understand kind of their situation, presumption of capacity.
Because there's a lot of, say for example, I worked in dementia care, and there's a lot of patient who has dementia but functioning normally, although they have cognitive impairment, and you wouldn't, because I had a lady who was on a DOLS for many years, and the DOLS assessor came to reassess her and said she has capacity and took away the DOLS, because at the time she was very, very, her capacity was, she was just like, everything was just flowing very well. The full conversation flowed very well. So it didn't show any form of cognitive impairment, although she had like evenings and nights. That's when her capacity fluctuates and her impairment really, because she gets aggressive, she does not sleep, she's very confused.
Sundowning.
Yeah, so
Okay, and just lastly, guys, thank you. What would make your decision kind of defensible then?
sometimes, does somebody want to say something else, or do you want to? Because I'm the one saying, yeah.
Yeah, guys.
You want to say?
More clear documentation. We mentioned about clear documentation and the following legal framework and risk management, how to manage the risk and safeguarding. And also we do include family, for support in case, and even the neighbors, family and friends.
Yeah.
Yes.
What support? The son's obviously concerned. We don't know the level of input and support he can provide. But what can we provide for carers?
Sorry, what?
What support can we? Because the client's not the only people that can have assessments.
We can include a package of care, like carers to come and. Assessments come from referrals generally, isn't it? Yes. So
how would we what would he need to do? What can we offer him, basically?
We can offer the son.
Yeah.
Sorry, I'm just for the son. We don't know how much care and support he provides to his mom, but we could offer him a carer's assessment.
Good job. Yeah, that's it. Yeah. Good job. Okay, no, thank you, guys. Do you have anything more to add before we move on to Group B? Patiently waiting. Thank you, guys. Anything? That was good.
Yeah, we can also give them information about food.
So people think a package of care is the most important thing to put in. It's signposting.
Yeah.
It's signposting as well. The information, advice, support given in terms of what they can do post-discharge, who they can call. That is what is integral for prevention and readmission, and also for them to support themselves. But also if they do unfortunately come back in, that's defensible. You've shown what you've done, the information you've given them. It makes it easier for your. Hopefully they don't come back in. That's the goal. But come back and say, we've tried this, we've explored this. This is the next thing we can do. So it leaves you. It wraps you up at a good point at this stage and at this time. Because remember, it's about a time they were like this. You can compare it to like this, and then you can see a journey. That's why documentation is very important. Yeah. Okay. Good job, guys. Thank you.
I was just gonna say that I had a character assessment that I completed.
Yeah.
And after everything had come through and the financial assessment, everything, and ready to put care in for the person, they declined it on the basis that I've given them enough information. And they have like families around to support, and if in the future they find themselves struggling, they would come back. But with the information that I gave, they felt that they could
So
manage.
where was that family support when you were doing your assessment then?
The family support it's not a lot of support. It's a young carer he's 17 years of age. He needed to be either in school or some voluntary service or hanging out with his friends and whatever. But there's some problem with documentation for the young person. However, it makes it difficult for them to go into school or education or any other system at the moment. They're still in waiting. So the person, at first, he agreed that he needs to be hanging with his friends and, just socializing. But then after, I think there is a situation. Culturally, they would not like to have people coming in their home and invading their private space. So for that reason,
but because of the information you gave, it meant that there was alternatives and options outside of that original support. Yeah, so we didn't have to rely on that.
Yeah.
There was other things to draw on.
Yeah.
Brilliant, and that's what's the beauty of it, and I think that's where people kind of forget it, but we rely on a lot of what's out there to support the prevention and readmission of people. Thank you so much. Thank you so much, great, right? That was brilliant. Round of applause, brilliant, good job, thank you. Group B, hi. Case study 2. You've had a lot of information from them. Thank you for patiently waiting. I'm just going to read through your case study quickly and then we go into the questions, yeah? So Mr. A is 62 and has been admitted with alcohol-related liver disease. He lives with his partner, whose staff report may be verbally abusive. Mr. A declines a safeguarding referral and states he wishes to return home. He has been assessed as having full capacity. The ward team are concerned about an unsafe discharge. Yeah? So who's the spokesperson? Yeah, Contori.
Yeah, so first question, we looked at the difference between actual risk and perceived risk. So starting with perceived risk, according to us, it's relating to professional anxieties, like the things that are not certain. So we're looking at unsafe discharge. That is, for us, that is the perceived risk. It's also influenced by professional defensive practice, just trying to not make a mistake. And then the actual risk is verbal abuse affecting well-being, the decline of the safeguarding referral. We don't know why he declined, so we will put that as a risk factor until it is proven otherwise. Further alcohol use is a risk to his health since he has alcohol-induced disease. And yes, we have the risk of partner giving appropriate care to him if there are allegations of abuse in the home. The law the human rights principles that apply for us is the right to private life, Article 8, and the right to liberty, Article 5. Our response. Yes, so looking at our responses, we do have quite a few, so I'll jump number 3 and go to number 4 first. Professional anxieties. So our professional anxieties, the first one is the ethical dilemma of duty of care versus respecting autonomy, and also the safeguarding versus autonomy. So we have to work around that because we have to balance the two.
Good job.
We also have the professional anxiety of professionals being blamed should anything happen to Mr. A if he goes back home. So should anything happen to him, if any harm befalls him, we have that anxiety that professionals are going to be blamed. The other anxiety that we have is organisational pressures to avoid an unsafe discharge. So you want to discharge, but because of the pressure, but then there's also the pressure of the unsafe discharge. So yes, those are 3 professional anxieties. With the response, so the case says, and he has been assessed to having full capacity. So first of all, for us, it will be the response will be, okay, so he was assessed as having full capacity, but capacity to which decision? So we would want to redo the mental capacity assessment.
Or just know what capacity assessment was done in relation to what specific decision.
Sorry?
Or to just know, full stop,
Yeah,
what.
or to know what the decision was about. But if it wasn't relating to what we want to know, then we'd actually want to know about
job.
that. Part of our response is to explore the allegations regarding the verbal abuse, firstly with Mr. A, to understand this verbal abuse allegation. Would also want to, so through this, while doing our response, I'll just then mention it. When we redo the MCA, we will document the MCA accordingly. And then we're going to have do a risk assessment of the actual risk versus the perceived risk, see how to navigate that. To Mr. A regarding the allegations, the safeguarding referral, and having to go back home, have clear recordings of all discussions, and then also have reflective supervision along with that. So on the final decision, everything again will be clearly recorded. Respect his decision to go home, but while respecting that decision, we will offer support and safety planning, i.e. referral to alcohol services, because alcohol was also one of our risks. And then based on our discussion regarding the verbal abuse, will see if there is any support that can be support and safety planning that can be put in place regarding the verbal abuse. And then explain to Mr. A that even though he does not consent to a safeguarding referral, as social workers, we have the right to override that consent if there is a significant risk of harm.
Oh, and are you overriding it in this case? Have you determined this?
In this case, we can't override because we don't know anything. So our main aim is to actually explore. Because we can't override because we haven't spoken to Mr. A.
So he has capacity. Are you saying you can override a decision if he has capacity?
He has capacity to do what? To what decision?
So what would you be doing? You said you would redo an MCA.
So we're going to do an MCA.
So what would you do an MCA in relation to what decision?
So we want to do an MCA to explore, for me personally, two things. To see if he understands.
So do you have reason to doubt his capacity?
Sorry?
Do you have reason to doubt his capacity?
Well, because if there is reports of abuse and you're refusing a referral, so I'm thinking, does he understand that he is being verbally abused? And that's if it's happening in the first place.
Okay.
So we have to, because before raising a safeguarding referral, we need to understand what actually happened. Is this a regular occurrence or is it a one? Because it was reported by staff, and
they have a duty to report these things.
Yes, they have a duty to report,
establish and figure out what is.
And we have now a duty to ascertain these reports, see if is it true.
Yeah, right, exactly.
So we will do that. We'll explore the concerns, and if they are warranted, and if the evidence proves that he is at risk of significant harm if he goes back home, we would override that consent.
Okay, interesting. It's good. That's okay. Are you finished? Is that no? It's good feedback. It's interesting. These cases I thought was a bit harder than because and this is I love it because this is real life. This is literally an exact example.
Maybe verbally abusive. Was there abuse or was there no abuse?
Right, good questions. These are the kind of questions you should be asking. This is what's really important because this is a type. This is literally in the referral we get, we'll have something like this. Straight away, it's the inquisitive, like I had to work with them to be more, because safeguarding is everybody's business, yeah? You're not going to send it to me and me figure it out. You have responsibility of the ward. That should have been established. Because when you're sending a referral to us, you're essentially, establishing that it is. But when I'll feed back when you are finished over there. Have you got any queries or feedback? Yeah, brilliant.
So it was just a thought when we were discussing about this case. In our group, 3 of us hesitant that it's unsafe where he is going to back to his home because and also 2 of them agree that he should go back to. I mean, get discharged.
Okay.
Yeah.
Good. This is good.
Yeah. So. Yeah.
So who said he needs to go back home, and who was hesitant about him going home, and where was you going to send him?
Oh. Yeah.
No, we say he should go back home. We say he should go back.
Okay. And who was hesitant? Okay.
Yeah. We 3 were hesitant.
So where was he going to go?
Yeah. I mean, so.
Where would you send him if he can't go back home?
I mean. Because
No, where would you send him?
No, like stay in the hospital until he has like a full health assessment.
Stay.
Yeah,
no, you're going to do the full health assessment. Well, I need an outcome. You can't stay in hospital. Don't you know the warder chasing you down for the bed?
Yeah, no, there's no.
He's medically fit. Hold on, guys.
And also.
Hold on, guys. Hold on, guys. Please.
Yeah, and also when it comes there, maybe if. There are options where the carer in his home, maybe if doesn't have the capacity to care him, they can actually refer him to a supported home or like that.
Sorry? Okay, cool. Look, no, good job, guys. I want to before we go because I want to so we don't go that too deep. But do you want to? Do you have something to contribute? Are you sure? No, you can. Yeah. No, guys, brilliant. And I'm so glad because that was the whole purpose of this study. This is to cause that this is harder than the first one because it's a balance of individual autonomy and professional kind of anxieties. Yeah, and that is the conflict. I honestly don't care about professional anxieties, and that's why because the ward are so risk averse, and they're very. But we all should be thinking about safety and stuff like that. But it's spot on. You picked up the theme, and it's really important because the ward team are concerned about an unsafe discharge. I've left it ambiguous for a reason because they always are. Because they, like you said, you highlighted, don't want to be blamed. Please, come out of that kind of thinking because you will always then go into a situation of, risk-averse practice and, over-prescribing. But you know what? When I come in, you can't justify it and then you get angry at me. Because all I'm asking is, okay, so how did you come to that? Because I genuinely need to know and understand because that, you're pushing then on us to place him in a care home, for example. Number one, he's 62, you don't even meet the criteria for a care home. Yeah, 65 plus. So we're looking at supported accommodation. Land registry search, does he even own his home? We're not sending him outside somewhere in his home. There's another thing here. We're talking about a situation. This whole safeguarding is the reason why we're saying he can't go home. Who am I to get involved in a verbal disagreement with his wife? How do we know their dynamic and setup? How long have they been married for? What is their dynamics of their relationship? And we often get caught up in personal dynamics, right? And mistaking that for safeguarding. That is really important for us to discern, and that is probably one of the biggest things we get caught up because, boy, if you heard the way we all speak to each other, do you know what I mean? People consider that to be, not really, but you know what I mean, abusive. There's cultural elements to it. How long has he been drinking for as well? Right, this someone who has alcohol-related liver disease, you've been drinking for a long time. This is normal. Remember, a lot of these people, unless we've established that has he had care and support before? If you looked at his file, how many times he's been admitted due to alcohol-related? Again, it could be managing or it could be reoccurrent, it could be and that all informs the situation. Is it constant reports of verbal abuse, and the reality is here, what we're looking at amongst all of that, it's about history and background. It goes back to who is this person? We're coming in at a point in their lives and we think we're going to disrupt we have a really integral and important role, but we also have to understand where we fit into that kind of dynamic and situation. Now, again, this could be what we kind of need to establish is verbal abuse. What did she tell him to shut up? Or, did she, we don't know.
Just be upset.
She could be upset. He's drinking, he came in late. It's about understanding the degree of that because he's going home other than that. He has capacity. That whole safeguarding blocks discharges. Those are our biggest delays. And a lot of the time, it could be a simple conversation to have and establish what's going on. Remember, he wishes to return home. So whether he has capacity or not, we look at someone's wishes. If they have a wish And they could lack capacity to be consistent in the fact I want to return home. We will consider that and put that at the forefront, irrespective of anything. We won't override nothing. There's certain circumstances, but where someone has capacity, but even if they don't, they have that wish to go home, we always lead with least restrictive and home first, full stop. And if he owns the home jointly with the wife, actually, it's kind of like, you know, and who's considered to be vulnerable here, actually, because they both could be in different circumstances, but, you know, it's about what support he's had, what support does he want going forward, but how can we, support them to best manage their dynamic. We don't want to be involved with respect. I say to social workers all the time, why do you want to hang on to cases all the time? Case like this, why do you want to hang on to it? It's not straightforward and easy, but it becomes complex because of these certain things where we're managing our own personal anxieties and feelings and need to go back to managing what the reality of the situation is. You were right to personal and private life, which brings me back to the point of those dynamics. Do you know what I mean? Like that's also, we have to consider that, but we don't want to judge it and base the whole thing around, you told your wife A, B, and C. Okay, so how much did he have to drink that night? Well, do you know what? He was at the pub for the whole day with his friends and things like that. Is this a regular occurrence? It's that kind of question and that kind of degree. Who raised it? Staff, again. Did she have any issues with it? She'd be like, oh no, that's normal. It's just like A, B, and C. Remember, a lot of time we have a duty, but sometimes, again, they report anything and everything as well. People don't use that discernment to establish or use that further questioning. Is this really considered a safeguarding referral? Or is it something that can be managed with a family meeting or an MDT coming together? The least restrictive principle. So, listen, he has capacity. He's been assessed having full capacity. Like you said, we don't know what that's in relation to. Is it in relation to what? Does he have care and support needs? Your role as a social worker goes in, what are his care and support needs? Yeah? For me, I don't know, he's quite young. How is his, needs arise from a mental physical impairment? How is his alcohol-related liver disease impacting his ability to care for himself and live functionally and carry out his day-to-day activities? That is your focus, yeah? Remember, a lot of people live at home that are considered to not have capacity, and they live fine. They live in their way in their lives about managing them risks. He will go back to. You can offer him RISE if he wants to. They won't accept if you choose to, accept the referral. But it's like we have to kind of work with people in the way that they are. But maybe just introduce them the advice and guidance. But I think it's important here to talk to the wife. See that dynamic, because we are sending this, we can't ignore the concerns of that, but it's about understanding what that is and what that looks like. And also challenging the war team. You say it's unsafe. What assessments have you come that has determined that it's unsafe? You can't just make a statement and just throw words out like that without the evidence and the rationale to back that up, yeah? So brilliant. I think that's brilliant. I think what's important here for us to pick up is that the ethical tensions between professionals and ourselves and those challenges that we do have, recenter it back to what's important here, what does the individual want, and how can we support them using the legislation to get the best outcomes and come together. Remember, unwise decisions, it's allowed, and it's often quite common in our line of work. Thank you, guys. That was longer than I expected, but it was brilliant. I really enjoyed that. I do want you guys to have a 60-second reflective pause, and this is really important just after exercises like this, and just have a look and maybe write down in relation to these cases, or maybe just in relation to your placements, but particularly in a hospital, if you're in a hospital social work and with the cases you have, I want you to write down what are you most worried about? Yeah, what evidence supports that? What is proportionate? Whose voice is missing? And could I defend this ethically and legally? And this actually is me when I speak to my staff as well, because just you need to take a step back, right? Separate your own feelings, anxieties, your personal biases and those thoughts and feelings and your own experiences. What is the reality, right? But understanding how is that influencing what is happening and separating those things. And when you start from those, because your experiences also are important in dealing with people. Like I said, I'm West Indian. We're not all the same, but I'm saying that there's certain cultural things that you understand, the way they speak, certain things that people would interpret as, they lack capacity, and think, no, you just got to ask people in the right way or meet people. I'm from South London originally. You can hear it in my accent. Sometimes you've got to tap into that kind of side of myself. And then, I am young and I've been in the work that I do, and I can understand I may not be ready. Look, what do you know? you know what? Not as much as you, 90-year-old Jenny from down the road. Do you know what I mean? I may not know, but it's in a different way. I'm here to bring a different information and expertise into your life. And it's about acknowledging how I'm perceived, but how much of that should I be aware of and internalize, and what is that, how much of that it drives and gives, it's a strength, essentially. Yeah? So have 60 seconds, just a minute before we have a break. You've done really well, guys. Just to reflect on those questions, write some things down, please, in relation to it. And yeah, it's a reflective tool. This is the reflective tool. I did print it out for you.
Is it that's reflective? Is it about the case studies that
So-
we just done, or
so-
is it about our own?
So I think for me, I said in general, because in the placements that you do have, but I think because the case is probably most relevant and it makes most sense to do it in relation to the case. But this is a tool. I would say it's not in a tool format, but I want you to take pictures of this and use that when you go into your placements and just in life in general. Social work, I always say I love social work because it's just an extension of my values. How I am personally is not too far how I am professionally. So that's why it's not hard for me. It challenges those sides of me that need evolving and growing. But I'm very reflective. I do think a lot. But I also care a lot and I'm very passionate. Sometimes it's easy to get engulfed. So you have to take a step back and think, okay, what's worrying you? So you can take that into any element of your life, an area of your life, but in your jobs as well, separately, your placements that you have, they're really good reflective pausing points, yeah? So take a minute, even in silence, you can meditate and reflect if that's what works for you. But I'll just take a picture of it, yeah? And then after that, you have a break. Lucky you. You've done really good. Really well. How are you finding it so far? Oh, you're meant to be reflecting, sorry. Does that mean there's too much? Too much information to take in? Really? Don't worry, I'll leave you with the presentation slides after. So we now kind of move on to section 3, which is power, ethics, and professional identity. And you'll see that we kind of spoke about these things throughout the beginning, the case studies, briefly. And it's just about balancing autonomy, accountability, and organisational demand. So, it essentially explores power because decision-making essentially doesn't happen in isolation. It requires the support of the MDT, different professionals. And a lot of the time, they like to use when I said, we lead discharge, they also like to use that against us. You make the decision. It's like, I'll make the decision, but my decision is informed by your valuable expertise. And, you put it back, it's like, I need you, actually, we need you. And they don't like that because it's kind of like, again, it's reminding them of their input when it's necessary. So in hospital settings, decisions are rarely made by one individual, unless they have LPA actually, then it's over to you guys because we have no jurisdiction to intervene unless we believe that you're not it just doesn't make sense, acting in the best interest, like wanting care but not wanting to pay for it or but yeah, they can make a decision to place. I think a lot of people, when they come into practice, not into practice, but the importance of having an LPA and what that actually means, I think people take it for granted. You're appointed, but until you're required to use it for it to be in play, people get really taken aback. And we're not here to just leave them in isolation. We still support them and guide them, but where that a responsibility falls is whether it's with us, so if they want to go in place and we've kind of established that they can go home with this level of support, but they decide they want to play, that's over to the ward. You guys manage that and support them with finding homes. Anyway, so in hospital settings, it's done by a multidisciplinary team and we work in a way where everybody is included. So we often sit down, particularly with complex cases. I encourage the team anyway to, before you have your assessments, have professional meetings first. In complex cases, it's required, but I'll just say meet with the professionals anyway, because we receive the referrals from them. So how have you kind of understood that this person actually needs our care and support? My first thing is, okay, so what you sent this person into us, you've come to a conclusion or established by some, this person needs care and support. It's often stopped by then because the first thing is, did the person consent to the referral? Yes. So why is it when we've got there, they're saying, I don't want this, a lot of the time, did you even ask? that's where I've even stopped. I'm always, one thing about me, I'm finding out, do we actually need this? I've got to manage my resources as well. It's easy to dump. Oh yeah, no. And they've got into a practice now, the MDs, the complex discharge team, to kind of manage that, because I've been able to successfully highlight the poor referrals and, you know, log that and document that, and then be able to send that back and be like, out of the 15 you sent, 2 have come back. That is real. That's not normal. And normally we would absorb that, take it on, and then we do we waste all our time and establish this person doesn't need care, or they've got a private care in place. Those are conversations that should have been had at the beginning. So, so the decisions are made in the multidisciplinary spaces, such as the ward rounds, the hub calls that I attend, the MDT meetings where my managers, you know, that's only when it gets to escalation. They unblock those complex cases, discharge meetings, and safeguarding discussions as well in those meetings. Those spaces are particularly important because they bring together professionals who have different views, expertise, experiences, and it's a forum where we share those ideas and come up with a plan that works in the best interest of the client. But we also have different roles and responsibilities, and we're accountable for different remits. It's not about challenging, well, it is actually professionally challenging each other. It's more about finding ways to support one another as well. People in those forums often have a different level of influence. So yeah, that goes on to, again, back to the medical and social model and how the structure in the hospital kind of works compared to us. Oh yeah, it's here. So medical model versus social model, language, shaping outcomes, hierarchy in meetings, and professional identity. Now, in social work, you know, you have a team manager, senior, would be me and the staff. In the hospitals, the consultants, I would say, and it's blasphemous, but they're seen as like the god of the hospital. Oh my gosh, nothing kind of goes, which is fine, but the way in which they are like, for lack of a better word, I say respected. I think we'll be quite polite, but respected or is insane. Often it's like the consultant said that, and it's like the nurses are so integral. You are their day-to-day with the patient. You are carrying out what the OTs have assessed, and you're putting that into practice. You're there day to day. Like, you know, your input is equally as important. Often we've done got to a stage of a discharge, and then the consultant out of nowhere, I didn't even know you existed. What part of this process were you in? I didn't even know you were in this case. Where were you? And suddenly they said, not going home. What? And I think because of that level of respect that they have and that authority that and power they have in the hospital settings, they're often shocked when I don't necessarily care. I do care a little bit, not really, because it doesn't work like that. We work in a different kind of way, and you will still have to also account for why you are stopping a discharge when you are also the same person who is pushing for bed capacity. Yeah, because it's not because I said so, and you're not going to highlight things that we've already sat down, had meetings to discuss, and that's often where it comes into that assertion. I respect everybody. That makes sense. No, that has it is that makes sense. You have my social workers and staff. We've worked so hard, and we've had the relevant conversations, and their staff as well. And then you come in and just change that, and that is the dynamic that they respect and have to go by. There's almost a fear, I would say, to challenge that or go against that. And I've also had to be aware of that in terms of when I then challenge that, I can't come in and undo a culture. So there's that organisational culture, and I've had to kind of work with them in a way, almost empowering them. But I'm not their boss, I'm not their judge, but it's just that you have your own legislations and ethics and codes of conduct that you can also use to support you, but sometimes that overrides that. So in healthcare, they operate, like I said, within a clear professional hierarchy, the consultants and the doctor. I don't know their hierarchy, to be quite honest with you, but they're clinical. And medical teams hold that clinical authority, which is fine. But I still have to understand it in a way that informs us. The nurses hold the day-to-day detailed knowledge, very integral, very important, because that's exactly what we're going to need when we're doing our support plans and what the carers are going to emulate at home. And the therapists focus on the functional ability and rehab and the physio input. So our input in all of this is that we bring that we bring it together. We bring that holistic perspective around autonomy, safeguarding social care needs and capacity and that whole context. All of these perspectives are valuable and integral and important, all of them. You know, I have my own feelings, but that doesn't negate, I respect everybody in their individual remits until I don't. But I've also had to understand that your role becomes complex because, again, we have to kind of question things, and consultants and stuff don't like to be questioned. It's what they say. When I was a student, I remember I was in mental health at one of the mental health hospitals, and do you know what it is? I think it's more of a like, don't be rude. Don't be rude, but you know, I was young, really young in my, I think I had my pet, and she was sitting there and I felt really bad, and just trying to speak, and the OT was like, said something. And I think consultant just came in and he started talking. I said, I'm really sorry, can I just finish what I'm saying? I just, I think everyone was like, but that's just, you can't, who are you? And that's just respect. And he was talking and he's like, just comes in and just decides that it's not that, whatever. And then I said, that's fine. And I explained, and he was interrupting me again. I said, I've let you speak. I'd be respectful, got up, the meeting's done. So I kept talking because, okay, you know what I mean? And the OT was like, he said the meeting's done. And I said, that is your God, that's not mine. And I meant that in terms of that. And that was it's probably my, but I was young, but that was a really like brave thing for me to do. But I also understood, wow, that's the first experience I got an understanding of that kind of authority and power they have. It was unbelievable. Like, got up. It was so dramatic as well. I think that's what kind of put me off, gave me the ick a bit. And then I sat back, and then the OT was like, I said, with all due respect, you do not know what experience and what background and what knowledge let's all stay in our lane. But you're not going to encourage me to accept that behaviour. I can understand it, but I won't accept that, because ultimately it's professionalism. We have the patient sitting right here, and you're saying things in front of her that she can't go. She's not slow. She may have some mental health. It's really disempowering. It upset me, not for me, but for her. And do you know what it was? I did cry. I tell you why, because I was probably angry, but I was like, I'm not going back there. I said to my manager again, I said, I will not be going back there. How dare you? And they updated Rio when we had access to Rio at the time, and they tried to say I was rude or whatever, which I just felt as well, again, was unprofessional. But he's like, do you understand it? Do you know the expectation they have of you've come in and it's you that is, because all I was asking for is like, I just want to be able to know what to write in the care plan, yeah? What I didn't realise they didn't know, because they had her sitting there, they didn't assess her. They didn't do anything. When they determined that she wasn't necessary for that unit, they didn't do anything. And inadvertently, unknowingly, I was challenging that. And I didn't know, because all I wanted to know is like, okay, so what's happening so I can fill in my assessment, we can get her out. But I didn't realise that until after, and it was like, wow, it's kind of like, it's easy to take things personally. I was young, I was like, I will not be going back there. He was like, don't get upset. I was like, no, I will get upset. But that's going to happen. Let me go through it. But it was a good learning experience, but it made me realise from that day, and then I've been on a mission since, never let anyone, joking, not really. I just showed my student, I will always be me. And I remember as I'm older, I had my student, and I said, I anticipate a complaint, right? If you don't get a complaint, I feel like in your social work career, it means you're doing something right, guys. You need at least one complaint. There's not been one complaint about my practice, which, but, they don't like to be challenged, and they were all sitting, the doctors in their meeting room, and they were like, yeah, she can't A, B, and C. I said, well, they're like, well, we said, because of whatever, what the consultant said. And I said, you could tell me the sky's blue. I will still challenge it and ask you questions. Did not like that. Oh my gosh, because you're not going to challenge the consultant. You're not going to challenge what they have to say. That's not my job, that's you guys. If it stops there, then no one's going home, because I need to understand certain things. And the complaint did come through, but it's another day. But it was nothing to do with like my practice. They just felt, when you read it, they just felt kind of, it's ego, and kind of offended about how dare I question that. Well, I still work there, and they saw me again every day. Do you know what it is? When I come in, they're like, oh, you're Tiam. I'm like, it's me. And I'm lovely. I'm really lovely, but I know my stuff, and God forbid I come in and I expect everybody else to know what they should know, and I want you to tell me what's important, and you know what I mean? But yeah. So when we look at healthcare settings, I just feel as though that they don't always carry the equal weight, especially ours. It's picking and choosing. We've been fighting for a long time to be able to make it a bit more balanced. It's more about language for me, and that's what's really important. And we go back to the terms medically fit and unsafe, which was a big one in case B. And language shapes how decisions are made and perceived massively, yeah? So when we describe a discharge as unsafe, you mentioned that it can bring a sense of like professional, I don't want to be blamed, that kind of, it automatically goes in. Someone said that, the medical team have said it's unsafe, okay, everyone's worried about now it being blamed if someone goes home. We're thinking from that kind of perspective. We're all professionals here who have an abundance of knowledge and expertise. Why have we gone straight into crisis mode and not into we're the best people placed to be able to, it's about shaping your thinking and reframing that thinking, which is very hard to do with an MDT, the medical team. And that kind of like conflict, and that's why relationships come in and building that is important. But the same situation that's described as unsafe can be described as a managed risk, yeah? And it's about building a kind of plan that's proportionate and manages that risk and recognising that risk can still exist. We can't eliminate risk, it's there, but we can manage it and make it safe. So someone's at risk of falls. Okay, OT, that's over to you guys. What can we do? Handrails, make sure it's like uneven surfaces, care falls alarms. How can we support this person to remain as independent as possible in their home for as long as possible? Alleviate that pressure on the services. And that is a kind of our role as social workers, to reframing those conversations in more of a positive and empowering way, and bring the attention back to autonomy, rights, and proportionality. Yeah, I love that word. That is probably like my favourite word, one of my favourite words in social work. Proportionality, and there's another one that they keep saying, you really love that one. When I find a word, I hang on to it. But here. So there is rarely a perfect decision, only a defensible one. I don't care what my social workers come to, back it up. Because the thing is, how did you get there? That's okay. As long as you can defend your rationale. It's not about right and wrong to a degree. It's not about that at all. It's about how did you get there, because you got there somewhere. And that's what I encourage. It's not about what the perfect answer is. It's about, you've obviously done, there's always space for more probing and thinking, that's where I'm coming. That's why you don't sign off your own assessments, I do. And it's never, I always have something to say. But I'm always gonna, because it's just from a place of understanding. If I do, then the patient's if they get their support plan, they're gonna have queries about it. The family member's gonna have queries about it. That's why we don't write in jargon. What does that mean? You don't know because you copied it off the referral. What's QDS? No, 4 times a day package care. Everyone writes things out in full. We're empowering. We're not going to disempower people with terminology that they're not, familiar with. And people don't realise how they think they're in such a safe place in the hospital. Not taking away. You are to a degree. You get your treatment. You need to get out. You're at risk of hospital-related infections and diseases. Further deterioration in terms of your mobility the longer you're in that bed. People think, they've got 24-hour support. No, that's a one-to-one. They're in a 24-hour environment. That's why people think a care home. What do I do? What's your understanding about the care and support a care home provides? Someone's going to always be there. Okay, but where is it being assessed that that person needs someone there all the time? Because it gives you peace of mind and comfort, but it's not what's in the best interest of the patient. And you see where you have to separate those two things. Still acknowledge that, but we can, so my nan has dementia. And she's so funny, but I've got cameras and stuff. Speak to her for it. She's fine. She worked it, but that's what I've done to set things up. People often don't know about to do those things. It's a lot cheaper than a care home. It gives you peace of mind. You can check in, talk through. It's little things like that. So it's about those are the types of conversations we have and the types of technology that we introduce. Yeah. So. Just a question for you guys. Has anyone seen how, language influence, and how the language may influence decisions during their placement at all? What placements do you have? So, where are you guys?
For me,
Yeah.
So I was
You just take them off.
I was in a preparing for adulthood team, which was mental capacities, was the CARE Act. However, it was for disabilities.
Okay.
So just preparing them to live independently.
Transition.
Yeah, transition in team. But it was from 17.
What types of words or language that are used to that are,
When I read a lot of things, it was what I noticed, I think mainly was a lot of they can't do, or they cannot do, or written quite negatively.
Yes.
You know, like, or I'd be reading through it and I was like, okay, so what can they do in comparison? Okay, they may not be able to do that.
Why are we starting with
but they
what they can't do first?
Yeah, you know, like, it was very, very negative. And there was a couple of times I sat in quite a few things and I was like, well, can I just stop you? Everybody's saying that he can't do this, but can we start with the baseline of what he can do?
And then fill in the
And
gaps.
then we'll fill in the gaps of what he can't do. Like, and I just couldn't believe it.
Yeah.
And I was a student as well, and it was working with the local authority because he was in care.
Okay.
And, you know, I literally stopped the whole meeting. I was like, well, hang on, I can hear a lot of I can't. I don't like the way this is going. And I was there because I was taking it over, but I hadn't actually taken it over yet. And yeah, it was a lot of can'ts for me. And I was like, I don't like this. Like, can we stop? Can we just see where the baseline is and then we'll fill in the gaps as we go, rather than can't do this, can't do that, won't be able to do. How do you know he won't be able to do that? He can't do that at 17, but how do you know he won't be able to do that at 21?
They know he can't, but how do you know that he can? He
can't do that at the moment is what I like. Not he won't be able to.
But what's your assessment of that? What's the evidence to support that?
Yeah, and
like, it's all
so
about. How did they respond
mine.
to you when you kind of put that forward? What was the kind of response that you got when you kind of?
Everybody kind of stopped and was like, yeah, you're right. And obviously the social worker that was dealing with him afterwards, she said, I'm actually really proud of you. You know, well done, thanks. You know, like, and I was like, well, why haven't you ever said this? You know, actually, I've read some of yours. And I even challenged her and I was like, you know, you didn't tell me what he can. I like to hear what he can do, because then you can, you know, measure it between the comparisons of what he maybe cannot do.
And then
she was like, do you know what, fair. And
that's so good.
Yeah, so I got really glowing reports from that. So, but yeah, it was really...
It's a hard place to be.
It just gritted me a bit and I was like, oh, I don't like that. So,
that's just really positive
but
feedback.
a lot of negative, I think, language.
So as in
he won't be able to.
Well, what,
he will never be able to. You don't know that.
It's true. I mean, there's
we
realism.
Put in place so we can.
But also, what about terms about being challenged or difficult, or, you know, in hospitals, non-compliant, you know, you're right, can't do, oh wow, there's so...
I read stroppy in one of them. She was very stroppy. And I was like...
Right, there we go.
Wow. Like, if I
God
was
forbid you're in a mood.
and you said that about my mum, and I read that you wrote that my mum was stroppy, she may be, but...
God, you don't want to see me on a Monday morning with no coffee or just woken up. Shopping.
Yeah, so it was very negative.
I always say, God forbid if I was in a hospital, like God forbid I'll be on a doles 1-to-1. I'll probably have a straight side room. Because of what? Because I can talk, probably. That's probably what it is. And any type of challenging behaviour, which is labelled, some people who can assert themselves, you're labelled difficult, aren't you? Oh, mate, you don't want to see, it's stroppy. God, but then those are the terms, and absolutely. And it's, you know, this, non-compliant, not engaging. And it's about, okay, so I can see on the behaviour charts that you've written down that you attempted to change the pad at 4 a.m, and then again at 3. I spoke to his wife and he doesn't get up till 10. I would be fuming if someone started. Those are little things. What is difference between what is a need and what is a hospital procedure or like protocol? The moment you like, these are, I love those kind of, because then it's like, they actually have to change people by default or attend to people 4 times. That is just their protocol. It doesn't mean that is a need. And they often record that as, needed this much intervention, and frame it as there's a nighttime need, and it's not the case. It's very interesting, and that's why you need to know people. Well, me and my partner, we stayed up. We went to bed at 10 and didn't get up till 10. So they've been out of the hospital longer than they've been inmates. So they've got more of a history out of the hospital. We still consider but this is not an artificial, it's a different environment, so it's in. What does that kind of look like? And we can only get it so right. We have to consider what's going on in the now. We also can't negate from the background. And it goes the same ways. They've had a numerous amount of falls and we're trying to get them home. But when you talk about falls risk, I'm always thinking about falls risk. Yeah, there's falls risk, but it's the degree as well. They've been in and out of hospital several times in a year for falls, compared to they had one fall and they had a UTI. Do you know what I mean? So yeah, very good. So anyone else have any language or phrases and stuff? No.
For me, I am in the I was in children and family safeguarding team for my first, and I never really had a lot of languages in terms of what. But then I'm in mental health, adult mental health, social care team in Harrow at the moment, and within the cases that I am working with, allocated cases, I see a lot of declined intervention, refused, non-compliance, non-engagement, and things like that,
Yes.
and do not. So those are the things that I find, and unfortunately, sometimes it does not correlate with the support plan that I work with. When they, you see information being presented one place, but then it does not correlate to the person on there. Because I had, say for example, I had a client who, they said non-engagement with the service, non-engagement with the other 5 members in the supported area, non-engagement with professionals or anything. And I went in to do a subsequent review. I contacted prior to going in, make arrangements, and unfortunately the person did not engage at the time, verbally spoke behind the door to me to say, come back another day. And they said he will just come in and spend like a minute, and he left. However, I went in for an hour and 10 minutes, and he sat the whole hour and 10 minutes with myself and another social worker and the service provider staff, and expressed all his wishes and everything that is going on around him in terms of, the placement, his support needs, what support
So what
he's
difference
getting.
do you think?
So I feel that sometimes I think it's just, sometimes it's the way we present ourselves to our clients and try to get information from them, the way we approach them.
How did you approach them that you feel may be different to previous?
For me, I spoke with him prior to. I make time to listen to him. I show that I was ready to listen, and I tell him everything, that the reason why I was there and why I want his involvement, so that I can make decisions based on his information and in his best interest.
And not anybody else's.
And not anybody else's information. And he gave everything that was necessary. And however, it brought up situation which I had to raise a safeguarding. So that's
sometimes things can come out of that, but I think, just to go on to your point, I think also to highlight the frequency. I don't remember when social work became a one-stop shop.
Yes.
It does, because you're limited for time and resources, but
Yes.
mate, if I could 1 minute, I'll come back again.
Yes.
If that's still engagement. He's still not engaged. You didn't open the door, but you said, you get people just think, okay, it's done. A lot of the time, so did you go back then? Oh, well, okay, we didn't MCA lack capacity. Okay, it's the 25th of August, the last when they lack capacity was an admission. Have you gone back? No, not even capacity, functionality, couldn't walk. Okay, you lost. So what's happened in the 25 days? Did you, they were very unwell. We considered they weren't well at the beginning of admission. Did you go back? Sometimes it takes more than, and sometimes we all have limited resources. I'm sorry, we do. But I know the medical team are sometimes a bit more of a priority than it is us. But mate, we have to go back more than once. So it seems that the frequency and the time, and that showing that in your actions, that you come back.
But also, I have professionals who have been told the same thing verbally by the care provider or the placement provider. However, they find that the information that is shared is just based on, I think, the staff thinks that if they give you that information, because if you as a professional go to see a patient who is living in a place.
We only have 3 more. Okay, sorry guys.
and they tells you that oh, he's not here at the moment. He doesn't want to see you. He's not gonna engage with you. So these are things that makes it difficult. Yes, they will tell you as a professional that he's not gonna engage with you. So no point, stuff like that. That kind of brings it to that level where you don't get to engage and they don't get the opportunity to. Sorry?
Thank you, guys. No, we only have a few minutes left. There's not much left anyway.
Okay.
It's literally rounds it up and can move in, but I really appreciate that feedback. I think in general, in terms of non-compliance and stuff like that, it just kind of highlights in terms of how language can shape. When you label someone or they're labelled as these things, you automatically go in and people just go in with a presumption of that kind of feedback. But it's important for us to kind of reframe that, unpick that. What does that actually look like? Because you can imagine, I'm probably labelled as moody or whatever. Yeah, I probably am, but why? Is it the time of the month? Have I had a stressful week? Like it takes that person to kind of want to unpick and understand why. And that's how I kind of roll and remit. We haven't got long left, so it's more, it's about the kind of pressure and emotional labour I'll move on to, and it's kind of the well-being and resilience. Naturally, hospital environment is fast-paced, intense pressures, as we kind of discussed in this whole presentation, and that essentially can take a toll, especially if you are a kind of neurodivergent like myself. It's about understanding how to manage that, because people don't understand you and you're perceived in a certain type of way. You're so used to kind of masking and not. It's a worry. Like, I speak very fast. Hopefully it hasn't been too fast, but I am aware and conscious of that. But I also know that it's boring sometimes when people are talking too long. But it's about understanding yourself and people and how you're perceived. And a lot of people don't know those interrupting as well. Like I'm just like having to wait and not cut in and being conscious of all those things. But it's also a strength because of the kind of thinking. I've probably thought about everything. That's why I ask a lot of questions. Okay, how? What about that? And the staff, they're like, oh. A lot of the time they haven't thought about it. But that's kind of how I work. In terms of like burnout. So burnout, are you guys aware of burnout? Mm-hmm. How do you guys kind of manage your kind of well-being and emotional well-being? Kind of what does that look like? And we only got a minute or so left. So just what are ways? Good job. Yeah. Supervision.
For me, I take time out after, like, say, for example, when I finish my placement days, I take time out to maybe go for a walk and just to relax my mind and take my mind off the day, reflect, stuff like that.
Okay. For me, it's like start work at 9, I finish at 5. Unless there's an emergency, I'm staying within the hours. Supervision is very excellent. You share that, and that space that's dedicated. It should be like monthly or more frequently. What about within work? What your colleagues, your peers?
Yeah.
That support system.
Lunch break, I think.
Boundaries.
Yes.
Making. And then recognising, go back to that 60-second, that reflection, that pause, are kind of like, what's happening right now and what's happening here? The system pressures are not your pressures, but they do professionally, but not outside of that. I think also on top of that, you have to acknowledge that, the system's anxiety becomes ours. You can't internalise it, and it's very hard to say, it's easy to do, but it's about firstly being aware, but additionally, you cannot pour from an empty cup and an empty nervous system. It sounds so cliche, but without us, and the people are not going to be able to go home and get what they need. So you have to be, but in the best place that you can be, and that requires the support of everybody, but starts from within and yourself. That essentially really is it. I wish I had more time to go into that. If you guys were on time, we might have. No, joking. No, but I really do appreciate your feedback and that kind of. They will have access to the slides. Yeah. Brilliant. That's what's important for me, and then it's just reflection. But that's kind of really it. We got through the body, and then the activity was most important. But I really do hope that it did evoke some thought and thinking and gave you kind of a perspective of this side of social work, and you have a bit of an interest in it, or probably scared you, but it's fantastic. It is great. It challenges you in all areas, personally and professionally, at a faster pace, but it really does improve your skills. But that concludes my session for today, guys. Thank you.
Thank you.